Good afternoon and welcome to today's IAC webinar, Building Blocks of Strain Imaging, Part 1. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC, ASE, and SDMS. And now I'd like to introduce today's guest presenters. With us today are Dr. Juan Carlos Plana and Pamela Burgess. Dr. Plana is the Chief of Cardiology at Texas Heart Institute, Baylor St. Luke's Medical Center in Houston, Texas, where he is also Director of the Cardio-Oncology Center and Co-Director of the Center for Advanced Cardiac Imaging. Dr. Plana is board certified in cardiology and echocardiography. His clinical and research interests include cardio-oncology, valvular heart disease, diseases of the aorta, and advanced cardiac imaging. Pamela Burgess is the clinical manager of the Cardiac Ultrasound and Stress Testing Lab at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. She serves on the IAC Echocardiography Board of Directors representing SDMS, is an IAC application reviewer, and brings over 25 years' experience as a sonographer. Both are true experts in the field. And with that, I will now turn this webinar over to Dr. Plana. Doctor?
All right. Good afternoon, everybody. So let's go ahead and get started. So let's start with a case. It's always about patient care. So this is the case of a 41-year-old woman that is diagnosed with HER2-positive breast cancer, and as part of her pre-evaluation prior to receiving this medication for treatment, which can be anthracycline followed by Herceptin, she is asked to visit our echocardiography laboratory for evaluation of her left ventricular ejection fraction. So for all of the sonographers that we have online, I want you to take a look at the 2 images and to answer one simple question: whether further cardiac workup is needed or not. So let's take a look at the first image. This is an apical 4-chamber view, and then the apical 2-chamber view. For all of the sonographers that I have online, I want you to ask yourself a question, whether you're going to go and look for the doctor that is reading in the echo lab and tell him or her, hey, I think that this echo is abnormal. Call the oncologist so that this patient will not get the therapy, or I'm totally okay, I think that this patient should be fine with therapy. So I always like to start with this picture. This is a picture of Halloween Day, which is very appropriate for the occasion. And you have over here 3 characters. You have to the right a pirate. The middle one is the better-looking one, which is my son when he was 4 years old. And then to the left, you have the guy that is dressed up like a chicken. And then the question that I ask you is, who is pedaling over here? who is really doing the flexing of the muscle. Is it the pirate? Is it the pirate, my son, and the guy that is dressed up like a chicken, or is just the guy that is dressed up like a chicken? So you realize that over here, there's only one person that is flexing the muscle, and that is the pirate, and that my son and the guy that is dressed up like a chicken are doing nothing. They are just enjoying the ride. They are not flexing the muscle, but when you see them, if this was a movie, you will actually see them moving, although they're doing nothing. So you may be wondering, why Dr. Plana is showing this image. Because as you see over here, this is exactly the same challenge that we have when we are trying to adjudicate regional function. This is a patient that had an infarct of the mid-left anterior descending artery, and despite the fact that that segment is completely akinetic, there's no flexing of the muscle, just like in the example of the bikes in the previous two slides, that segment is moving, as you can see it. And it's moving not because the segment is doing anything, it's not because there's any deformation, but it's moving because obviously it's attached to the proximal segment of that anterior septum, and that segment is tethering this akinetic meta-anterior septum, giving me the impression that there is moving, when the reality, there's no deformation, it's just movement out of the tethering. So what are the options that I will have to jump over that obstacle? One option would be to do what we just did over here, which is to do M-mode and to demonstrate, what happens through diastole and through systole, and you realize over here that the segment is actually having deformation. But imagine the effort that it will take to evaluate the 18 segments doing M-mode, for all of the hearts that we evaluate in our echo labs every day. So then what we need is a modality that will be independent from tethering, one that will get rid of that problem for us, one that will allow us to do characterization of myocardial mechanics for each of the segments, again, independent from tethering. The problem is that when all of you guys hear the word strain imaging, it sounds like you need to be a genius to understand that concept. And what I want to do in the next few minutes is, first of all, to just explain how simple the concept is and to make you understand what is the literature that we have available right now that proves that this strategy is better than the ones that all of us have used over the years, which is the evaluation just using ejection fraction. So what is a strain? A strain is defined as the deformation of an object normalized to its original shape. So in a one-dimensional object, there are only two possibilities. You are lengthening or you are shortening. So which object are we talking about? Obviously, we're talking about the cardiac myocyte. So if I were to calculate the deformation of this blue bar going to the extension of the blue bar, what I will do is I will do the following mathematical calculations. The change was 2. What I'm going to do is I am going to normalize it to the original shape, which is 7. So then the strain will be 2 divided by 7. And this is how I'm going to come up with the 28% strain for this particular case. So it is very important that you understand, and this can cause confusion, that you are going to have positive and negative values for a strain. So in the long axis of the heart, as you have seen in your echo machines, the long axis will get smaller when the heart contracts. Therefore, by convention, the strain, the global longitudinal strain, will always be negative, and we will talk about normal values in a minute. And then the radial strain, you have seen that the thickness of the muscle increases during contraction. So that, by convention, will always be positive. I don't know how it was when you guys took your classes about cardiac physiology, but when I did my training in cardiology, this is kind of the way that the contraction was explained to me. 3 donuts, each representing the base, mid, and apical segments of the heart, and the heart contracting, kind of going in a direction towards the inside of the heart in a concentric way. Nevertheless, our understanding has changed, and right now, the way that we understand cardiac contraction resembles more your grandmother trying to get water out of a towel. where you're going to have, as you see, the base of the heart, the right globe, going in a clockwise direction, and then the apex of the heart going in a counterclockwise direction. If you pay attention at this close, you will realize that then the fibers are organized in different ways in order to accomplish that. And I can assure you, if you have done the experiment of wringing a towel, that it is a very good mechanical exercise. You will realize that you are able to get the last drop of water out of that towel. So in order to do that, you require two helices that are connected from the electrical and the mechanical standpoint, and you see it over here under D. You have what we call the right-handed helix that is located going from the subendocardium towards the subepicardium, and you have the left-handed helix that is going from the subepicardium to the subendocardium. It is very important that you recognize what is the location and where are the fibers that you're interested in interrogating. Longitudinal fibers are located in the subendocardium, while circumferential fibers are located in the mid-aspect of the thickness of the myocardium, and this is going to become important when we talk about the clinical applications. So, if you are trying to evaluate clinical processes that affect the subendocardium, like hypertension, diabetes, hyperlipidemia, coronary artery disease, obviously you could be interested in looking at global longitudinal strain. So the technology that we use right now, it's called a speckle tracking. And it's called a speckle tracking because guess what? That's exactly what the technology does. It tracks speckles. So in the upper panel of this slide, you see two speckles. And what the technology is going to do is it's going to follow the distance between two speckles throughout the cardiac cycle. If the two speckles are getting close to each other, that means that that segment is actually having meaningful deformation, while if the two segments are keeping the same distance, what that means is that that segment is just moving without any meaningful deformation. So this is a normal strain. You see how each of the parts of the heart are actually in this apical two-chamber view labeled with a color. Red is completely normal with a strain of -20. You see how in the left bottom panel, you have actually assigned a strain value to each of the segments of the heart. You have the curves of deformation in the right upper panel, and then you have a color M mode in the right lower panel, looking kind of like a Hollywood red carpet, and this is how it's supposed to look for an individual that is normal. And I'm not going to stop over here because Pam is going to cover the interrogation of the normal patient in a more thorough way. So what are the normal values? One of the biggest challenges that we had when we were writing the expert consensus for the multimodality imaging of the patient before, during, and after cancer therapy was exactly this issue. What is considered a normal strain? And really the issue lies on the fact, as you see over here, that different vendors, in this case B1 is General Electric, B2 is Philips, and B3 is Toshiba, will have different strain values. You also realize that they will change as we grow older, and you will also realize that the strain for a female is higher than the strain for a male. So what is normal, if you're using General Electric for a female between 40 to 49, will be a strain more negative than -18.6, and for a male more negative than -16.8. So I'm coming back over here to the case that I showed you guys at the beginning of the presentation. I can assure you that I have shown this case all over the globe, and over and over and over, all of the audiences have agreed that they will have in their own echo laboratories called that ejection fraction normal. So let's see how normal it is. So over here, we are doing the speckle tracking. This is an apical 4-chamber view, as you can see. And you realize that the machine is liking the inferior septum, but it's disliking the anterolateral wall. When we come over here to the quads, you realize that the values that we're getting for the base, mid, and apical anterolateral wall, especially for base and mid, are kind of half what it's supposed to be for the inferior septum. And you realize that actually your Hollywood red carpet is kind of cut in the middle. We're doing the same thing over here for the apical two-chamber view, and you realize over here that it's picking up an abnormality in the mid anterior wall. You realize that the value for mid and for apical are abnormal, and when you take a look at your Hollywood red carpet, it's interrupted in the middle, letting you know that there is a problem there. So, as you can see, this case was back from 2008. I was at MD Anderson at that time. This was the first case where we use strain imaging for the interrogation of a patient. And as you remember from the initial presentation, it's a fairly young patient. So initially my colleagues, kind of throw apples and tomatoes at me, asking me, why is that you are going to interfere with the administration of chemotherapy? But I decided to go to the patient and to open the chart. And as you can see, it was not just the echo abnormality what we were dealing with. If you take a look at this EKG, this is a very abnormal EKG with deep inverted T waves, going all the way from B1 to B6, letting us know that this patient is probably somebody that has coronary artery disease. And we actually indeed took the patient to a cath lab, and in consistency with the abnormalities that we saw in regional function, we were able to determine that there was a very tight lesion in the mid LAD, and there was a subtotal occlusion of the circumflex, explaining the abnormalities that we saw in the apical 4 and in the apical 2. And if we had not done the strain imaging, just like I have shown this case all over the globe, they would have allowed this very sick heart to receive chemotherapy. I can assure you that probably this patient would have not tolerated it. This is the way that it looked when we did the bullseye. And then the question is, in imaging, we all like beautiful images. But the $1 million question that comes over and over and over is, the strain is abnormal, so what? So can you show me that using this technology, you are going to be able to either risk stratify the patient better, or that using this technology will actually lead the patient to a better outcome? So what I want to do is I want to show you 3 publications which I consider extremely important when you are trying to understand a strain. The first one is this one that addresses a very important question that we all are very interested on as clinicians, and that is the ability to identify patients that will die. So this is the ability to prognosticate death in the general population. So this was work that was done by Tom Marwick, who was my boss, when I was at Cleveland Clinic. And what he did in this study was something very important. He compared global longitudinal strain with ejection fraction and wall motion score index in the prediction of all-cause mortality. So he evaluated 546 patients. He used the Simpson's biplane EF and the wall motion score index, the way that you guys do it in your labs. Global longitudinal strain done in the way that I just showed you with a speckle tracking. The way that he did it is in a way very similar to the way in which we operate clinically. So he got these patients in a room and he asked them about clinical characteristics. So, to no surprise, age, diabetes, and hypertension were prognostic of mortality. We all know that. The question that he asked himself is, what is the imaging modality, either EF, wall motion score index, and global longitudinal strain, that has the biggest added value once you have collected this information about clinical variables? And it becomes very obvious by taking a look at the chi-square over here in this graph, that the one that gives you the biggest bang for your buck is global longitudinal strain, far superior from ejection fraction. So Why is it special? You see over here a cartoon of Mr. Magoo, and you realize that this is special because we are able to see, and you have the two images at the bottom, you are able to see things that we couldn't see before with this new technology. There's no way on earth that anybody that I know at ASC or at IAC will be able to recognize that there is a wall motion abnormality for the apical segment of this anterior wall, recognizing CAD in this patient. So the conclusions that Dr. Marwick came up with is that GLS is a superior predictor of outcome to either ejection fraction or wall motion score index, that it may become the optimal method of assessment of global LV function. As probably you have heard, a big epidemic that we are dealing with over here in the United States is the patient with heart failure. And you have also heard, how is that in terms of healthcare over here, we are going in the direction of the bundle payments, where they're going to pay us, a lump sum of money to care for the patient with heart failure. And if the patient turns into a frequent flyer, this money will be on us, will be coming from our wallets as opposed from the payers. So therefore, it becomes very important to risk stratify the patients and to know things that, again, are important for this cohort. And what is important for this cohort? Number one, our ability to prognosticate mortality. We want to know who is going to die, who is at very high risk, who is very sick. And also, we want to identify who is at big risk of getting admitted to a hospital. So what Dr. Marwick, again, did in this study was to compare the prognostic ability of the different modalities that all of us use in our labs. So to the left, you have just ejection fraction, as you can see, very inadequate in its ability to prognosticate. To the right, and doing better, you have filling pressures, the E over E prime from Dr. Naga. Then to the right, if you add the EF and the E over E prime, then to the right, if you have EF, E prime, E over E prime, and global longitudinal strain, but pay attention that the biggest improvement in terms of prognostication comes from the addition of global circumferential strain. And there is a very important explanation for that, and that is the fact that, as I explained to you, global circumferential strain will speak for compromise of the fibers in the mid aspect of the thickness of the myocardium. And what that will tell me as a clinician is that there has been progression of disease. This is not a process that is just limited to the longitudinal fibers affecting the global longitudinal strain, but rather a process that has extended, compromising the mid aspect of the thickness of the myocardium, letting me know about the progression and worse prognosis for patients that have abnormal global longitudinal and abnormal global circumferential strain. So he ends up concluding, as probably you have already, that GCS is a powerful predictor of cardiac events and appears to be a better parameter than ejection fraction in patients with acute heart failure. Now, last, and you guys are going to have another webinar dedicated to cardio-oncology, but in terms of the detection of subclinical LV dysfunction, I am using the example of aortic insufficiency. You all know that a frequent clinical scenario is the patient that has a bicuspid aortic valve, severe AI, and we are trying to find the magical moment to send this patient to surgery. We want to procrastinate the decision the best that we can so that the patient can keep his own valve as long as possible and as long as safe, but at the same time, we do not want to see progression of disease to the point where there is LV dilation and there is a reduction in ejection fraction. So in this study, what they did is they compare, and if you take a look at these patients that have the conservative management, this is what we call, and probably you have heard the terminology, the watchful waiting. So they compare what is different, for the 25 patients that remain stable versus the 8 that had progression. And as you can see, neither the ejection fraction nor the end diastolic volume or end systolic volume index became prognostic. But as you can see, what is different is the strain. The strain for the cohort that remained stable was around -19. the strain, the global longitudinal strain for the ones that progress were around minus 16.3. So if we use a cutoff of minus 18, and if you have patients that you're following like that, and if they are dipping below this magic cutoff of minus 18, it will allow you to recognize the patients that are going to progress to symptoms, dilation of the ventricle, or reduction in ejection fraction, as they were the events that were incorporated in this combined endpoint. Now, what is interesting for me about this slide is that we have been told that aortic insufficiency is kind of like a forgiving lesion, where once you do surgery, your end-diastolic volume and systolic volume will go down, and your ejection fraction will go up, and we will all live happily ever after. But if you take a look, the strain is abnormal and will stay abnormal in these patients, letting you know that the damage in the myocardial mechanics for this patient is permanent, and it will stay there even if you have replaced the valve. So I think that we have learned some important lessons today. We have understood the concept of a strain as deformation and how this is different from movement. We have talked about the normal values. We have talked about the principle of speckle tracking. We have talked as to how this is taking us to the next level in terms of our ability to sort out patients. How is that I can prognosticate mortality in the general population, and how is that I can better risk stratify the patients showing up to our emergency room with acute heart failure, or the patients where we are trying to identify subclinical LV dysfunction. With that, I thank you for your attention, and then I'm going to pass the torch to my colleague and friend, Pam Burgess. Thank you so much for your attention.
Thank you, Dr. Plana. My role in the webinar today is going to be more the sonographer's role with strain, which is an extremely important role. Much like anything we do in ultrasound, strain is very technically dependent. So it requires good technical skills with optimizing the 2D image and in order to provide accurate and reproducible strain results. Just remember, any error in our strain can directly affect our patients. So over the next few minutes, we'll look at the technical requirements of strain, some of the common mistakes that we make, and some of the pitfalls of strain. So we'll first of all look at the required images. Of course, with global longitudinal strain, we have to obtain an apical 4, apical 2, and apical long axis view. By doing this, we can do it from two different approaches here. We can acquire each view separately, or as you see in the top right, we can do with a 3D transducer, we can acquire triplane imaging, which allows us to acquire all three of the images within the same cardiac cycle. And the good thing about that is we don't have to worry about the variation with the heart rate like we would have to do with the images at the below where we're acquiring those separately. So we have to ensure that those are done close together in sequence and that we're seeing less than a 10% variation in heart rate. Okay, so image quality is a huge factor for us with doing strain. We want to ensure that we've optimized the 2D image. We know that contrast doesn't really work with strain. It confuses the algorithm that's used to calculate strain. So that's not an option for us. So we really have to put on our sonographer hats and utilize good optimization of the image here. So what we're very concerned about is obtaining a well-defined endocardial border throughout the cardiac cycle in each of the three views. Okay, other things that we want to avoid is foreshortening the apex. So you would want to ensure that your apex is open, that you've dropped down a rib space, and you don't have any foreshortening there. Also, as you can see in the bottom left corner, I'm going to try and point to this here, where part of the apex is off the sector. And, here in my lab, sonographers do things differently. Some of them acquire the images and do the strain right away while the patient's there. Some of them will acquire the images and then send the patient on their way, and what happens is they find out that things like this has happened, where part of the apex is off. So it makes it very difficult to obtain good strain when all of the ventricle's not even within the plane. So other things that you would want to keep in mind is to make sure that your views are all on-axis views. Okay, so no matter whether you're doing these from a triplane approach or whether you're separately acquiring the views, just make sure that you've got good on-axis views. And I think this top one here is a good example of one that's not quite on-axis. You can see right away that in this apical four-chamber view there, that the left atrium is not completely opened. Again, in the two-chamber view over here, you see that the left atrium is not open properly. So those are things that you would want to ensure when you acquire the image. Now, if you're using triplane imaging, remember that what we initially do is we kind of focus on the apical four-chamber view, and we really line that view up first. And then we look at our two-chamber and our apical long-axis views. And if they're not good on-axis views, what we can do is we can adjust the planes here to kind of bring those views into a better on-axis view if needed. Also remember, too, that we have to acquire at an adequate frame rate. 40 is usually our cutoff with frame rate, but we like to get it up a little higher if at all possible, just to ensure good results there. Okay, switching a little bit to image acquisition, another important factor is the EKG that we're going to be used to triggering these images from. And I always encourage my sonographers to make sure that, before they ever start the strain portion of the study, that they have an adequate EKG. This may mean that you have to replace electrodes. You may have to switch on the machine which electrode it's triggering off of or reading off of. And also make sure that you don't have any PVCs within your images that you require, or if your patient has AFib. AFib's probably a little easier to handle if you're utilizing triplane imaging due to the variations we get with that. So if not using a triplane, again, watch for your heart rate variation between the images because that's very important. We also ask that our patients suspend their respiration, whether we ask them to take in a small breath and to hold their breath, or sometimes we'll ask them to blow out their air and just hold their air out. This kind of helps with the image quality of it. Plus, and I'm going to show you an example here in just a minute where respiration was a factor in the strain on the patient. So also we acquire multiple cardiac cycles. We know that our machine more or less picks which cycle that it's going to do the calculation from, or on some machines you can actually pick which cycle you want to utilize. So just keep that in mind. But keep in mind too that you want multiple cardiac cycles to ensure that you can do your calculation throughout that cycle. So here's an example of a patient where respiration was not suspended. And if you notice, you can see the heart kind of moving back and forth here. The four-chamber view, which is top left here, almost becomes an apical five-chamber view with a motion. And if you look to the right, that should be your apical two-chamber view, and that one changes as well and almost goes to an apical long-axis view. But look at the bottom left, the apical long-axis view there, how it doesn't stay open. The ventricle almost closes totally off. So this is one that you would not want to use to do your strain calculation on. Another reason why, if your workflow is that you acquire your images and then send your patient on the way and not do the strain calculation while the patient's there, you would want to thoroughly examine your views, things like that, just to make sure that you have adequate views to apply the strain to. So we talked a little bit about EKGs. EKGs can create issues with strain. Here's a good example of one where the sonographer didn't really realize what had happened until after the patient had left. and they were required to measure aortic valve closure with our equipment. So she had measured it, and usually aortic valve closure is just past the T-wave here, and that's where she measured it at. But for some reason, the system pulled it up to prior to the T-wave. And so what we noticed is that the T-wave itself is slightly higher than the QRS, and we thought that maybe played a role in it confusing the algorithm there where it uses to calculate it. But if you look at this overall, there are several issues here, one being the aortic valve closure prior to the T-wave. The other is, if you notice, here's our baseline. The strain curves are all negative curves, but if you look at our bullseye over here, you see positive values there displayed in blue, which really didn't make any sense to us. But if you look at the global longitudinal strain average here is a negative 16.8. So it was felt that the issue here with the EKG probably could have been changed, to read off a different electrode or something that would have helped this, but we thought that the EKG issue here really confused the algorithm. Another EKG issue that probably happens a lot more than that is acquiring your images and having a PVC involved in it. And you can see here that the right away that you notice something's wrong with the contraction of the left ventricle there. So that should take your eyes to the EKG to check that out thoroughly as well. And we went ahead and just calculated it just to show you how it can affect your global longitudinal strain there. And again, it confuses the calculation of the strain. So, when you do we tend to have a little checkoff list in our head as we're acquiring these images now that I think comes with experience when doing strain is, check your images, make sure everything's within the sector, check to make sure that you've got optimal endocardial definition, check to make sure that you don't have any issues with your EKG as well. Okay, next we're going to kind of switch gears here and talk about placement of the region of interest. A lot of the machines now have automation, which automation is great, don't get me wrong, but realize there are some pitfalls with automation here. This one is one where we let the machine do the automation, and if we look at the bottom image first here, we can see where it placed the region of interest down below the mitral valve annulus slightly. Okay, and this can cause some issues with the calculation of your strain, so be real careful that the placement is right at the mitral valve annulus and not down into the left atrium. These areas are some of the most difficult areas to track anyhow, so we tend to kind of push those up when we're doing our region of interest placement, but just be real careful with that because it can affect your results. Okay, another view that it can affect it in is your apical long axis, because we don't really have that mitral annulus as a point of placement here. So be real careful not to go down into the left ventricular outflow tract. This one that I'm pointing to here is placed correctly, but if you look at the one below, it's gone down into the left ventricular outflow tract, and it will sometimes cause a little exaggeration of a bulge there in that area. So this is another thing that you would want to just spot check and make sure that you push it up out of the left ventricular outflow tract. Okay, region of interest width is another thing that the sonographer can control. You can underestimate your global longitudinal strain results if this is not set correctly. We want to ensure that the proper width is just so the width includes the myocardium and does not include the pericardium. So if you see it kind of overlapping over the pericardium, you'd want to just reduce your ROI width to where you're staying out of the pericardium. So here's an example that we just created with this one. You can see how fat or thick the ROI looks on this patient. And this patient's walls are within normal limits. They're not like it's a hypertrophied ventricle or anything. So remember that this will underestimate your global longitudinal results if you're out into the pericardium. And, you know, the thing about the equipment, it may track it like this, and it may tell you that the tracking's adequate, and you may get the green lights all the way across and move ahead with this. But look at the strain curve up here. Look at this one compared to the one below where we've reduced the thickness of the region of interest. Look at how nice and tight these strain curves are down here. I mean, up at top where it's thicker, we even have some positive deflections there. So this can very much affect your strain results. On the other hand, you can reduce the size and get the region of interest too thin as well. And again, this will underestimate your strain results again. The equipment also may indicate that you have adequate tracking here, and it is actually tracking fairly well. But we want to make sure that we include the myocardium and all of the myocardium, just staying right outside of the pericardium. Okay, sometimes we have to deal with structures that are within the left ventricle. The structures that I'm referring to are trabeculations, papillary muscles. Even when these papillary muscles are hypertrophied, it can become even worse, and the software will allow for tracking of the papillary muscle. Here's an apical four-chamber view, and you can see the papillary muscle right here on the lateral wall, and you can see how it kind of dips in there when the left ventricular wall itself is out here. So this can be fixed very easily by just going in and editing and pulling it back out to the lateral wall there. Again, apical long axis view here, we see where it's come in on the papillary muscle and track there. So again, we would just edit this back out so it's not tracking over on the papillary muscle. Okay, so kind of to reinforce all these points, I wanted to show you a normal strain patient that was done in our lab. It was a 47-year-old female who presented to an urgent care with a chronic cough and an unintentional weight loss of 12 pounds. They did a chest X-ray on her, which revealed a large mediastinal mass with lymph node involvement. They biopsied this, and it was determined that it was stage 2 Hodgkin's lymphoma. So they sent her to the echo lab to order a baseline echo prior to her beginning her chemotherapy. And I picked this patient on purpose because she doesn't make glass-chested pictures here, but we were able to get good strain on her. She had what was considered a normal ejection fraction. In these patients, we always collect the blood pressure and note their heart rate. Okay, you can see here where we did her images in triplane imaging, and we've got each segment or each view broken down here. So here's our apical long axis. We've got a good region of interest width on this patient. We didn't go down into the left ventricular outflow tract, and our strain curves look good on her. Again, here's the apical four-chamber view, not going down below the mitral annulus, and getting good tracking on this patient as well. Apical two-chamber, again, we stopped the ROI at the mitral valve annulus and got really nice strain curves on her. So we allow the machine to calculate all these three and give us our global longitudinal strain average. Hers was negative 18.6%, which was in the normal range for her. Okay, so kind of switching tracks a little bit, I want to just briefly talk about coding for strain. Right now, the strain code is a Category 3 code, or what we consider a tracking code. This code is used with emerging technologies such as strain, and we would want to encourage everyone to use this code So we can collect data on it, and this is critical toward establishing reimbursement with strain. I've got the code listed here, and it's an add-on code, and it can be used with the following base echo codes. So this is a collection of codes from 2D complete codes to limited to stress echo codes that can all be used with those and reported with those. Also, I want to make you aware that ASE has on their website under the advocacy tab that there is a strain code payer toolkit available for everyone. So that would be good to go and review if you have any questions about that. So hopefully today I've gone over some of the issues that you've encountered as a sonographer with strain, and this will help you to acquire good images for strain, to set your strain on your 2D images properly, ensure that you have good EKGs, all those things that are kind of the sonographer's role in strain. So now I will turn this back over to Kelly.
Okay. Thank you, Pam. And at this time, we'll begin the Q&A session. From IAC Echo, I'd like to introduce our senior clinical specialists, Sandy DePetris and Sue Jensen. Sandy and Sue will be assisting with the Q&A session today. Sandy, would you like to start us off?
Sure, Kelly. Thank you. The big question of the day, I think that some of these questions have come through, is if the transthoracic echo is a technically difficult study, is it even worth attempting doing the strain imaging?
I can speak from my standpoint as a sonographer. We always go in and attempt the strain unless it's just we can't, we feel like we're guessing more than we're placing in a proper placement for the region of interest. Sometimes it will surprise us and we will get strain results back. Other times you sit and you edit, optimize, do everything you can, and it just does not work. I always say everything with ultrasound has limitations, and so does strain. So, it's not quite there for contrast with strain. So there's not much we as sonographers can do other than just ensure that we've done everything we can with image optimization.
Okay. I have a lot of questions about arrhythmias, Pam. Everybody wants to know if they should be doing strain with AFib and PVCs and how that affects the outcome of strain.
Well, of course, you'd want to avoid the PVCs if at all possible. You can see by the case examples that I showed that it can create very erroneous results with strain. So, and AFib, I read very mixed emotions about that. Some people say that you can go ahead. Of course, triplane imaging can help you with the variations that we experience with AFib. But I probably would refer this to Dr. Plana to see what his thought is on interpretation of strain with arrhythmias.
I mean, what I have to say is that is it possible? Yes, it is. I think that the challenge comes from what Pam just mentioned, that you do not want to have a situation where the heart rate is too discrepant between the apical 3, apical 4, and apical 2 chamber acquisition, because the machine will not be able to do its job. So if you do the capture, with your triplane, you are really giving the best shot at that successful. Definitely the PVCs, I will not do it because, there is always extrasystolic potentiation. So you're going to have if you evaluate the one with the PVC, the strain is going to look better than what the real performance of the myocardium is.
Okay, Kelly, do we have time to do another question or two?
Sure, I think we could probably do one more if you'd like.
Okay, Dr. Plana, Tracy asks, I've heard that different vendors' values for the GLS are different. Is it the most important thing to look for changes in the patterns from study to study?
Yes. If you take a look at the expert consensus, we presented kind of two approaches. One where we will define a value of normality, and then we will consider abnormal if you go to a standard deviation below. But as you adequately point out, and as you saw from the slide that I showed from the Justice study, the normal values, differ in a statistically significant way across vendors. So therefore, the way in which we are jumping over that obstacle is by looking for a delta change. If you take a look at the expert consensus, the percentage reduction that will adjudicate subclinical left ventricular dysfunction is if you have had a reduction of more than 15% of your global longitudinal strain when compared to the baseline study. I think the important message is we recognizing the variability across vendors. We do not, switch from one machine to the other. We kind of try to stick to the same machine when we evaluate the patient. And the reality is that this is not an issue in most of the echo labs because we have certain vendors that we feel more comfortable using for function versus others, versus other studies. So we are kind of always using the same machine, and in many instances, it's actually the same crew, the one that is doing it.
I'm going to ask one quick question for both of you. There's a lot of questions about stress strain. Is this worth doing? Should they do it if they have it in a package? And right ventricular wall motion strain. Are there any comments on that?
So if I may, and then Pam, you answer the way that you consider appropriate. The problem of stress is the heart rates, and the frame rates that you will need. As Pam mentioned, you would like to have frame rates somewhere between 60 to 100, to be successful. If you are having a situation where your heart rate didn't go up a whole lot, it shouldn't be a problem. I mean, if you have an elderly person that was only able to exercise to, let's say 110 or so, it may work for you. But if you have somebody in the 30s, that will exercise to a heart rate of 160, there's no way on earth, because usually the teaching is that you would like the frame rate to go holding hands with the heart rate. So there's no way on earth that you will be able to achieve frame rates of 160. Now, if you take a look in South America, actually they use vasodilators with echo, and then it works out very well. I mean, if you're going to use adenosine or persantin, because obviously the heart rate is not going to go up a whole lot, and then you will be able to do a strain without any difficulty. Regarding a strain of the right ventricle, I strongly recommend that you guys do it, not for everybody, but for certain populations, and I think the one that will benefit the most from it is the evaluation of the patient with pulmonary hypertension. The strain of the free wall of the right ventricle has proven to be the best prognosticator of death in the patients with pulmonary hypertension.
At Wake Forest, we do not do any stress with strain. I agree with Dr. Plana that the heart rates are too high for what we're doing, what we currently have here. I have heard of some labs doing strain with their stress studies and are saying they're very successful with this, but I'm not sure how. We do a little bit of RV strain here, have attempted that. You kind of have to fool your system to go over to the right side of the heart, and then you just block out the interventricular septum so you're not contaminating your strain results with those numbers. But, again, what we've done here has been very limited with RV strain.
And with that, I think we will wrap it up. Thanks again, everyone who attended, and a very special thank you to our guest presenters today. We encourage everyone to register for Part 2 of this series happening on November 16th. Please feel free to contact IAC Echo with questions that were not answered during the Q&A session. To receive your continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars, look for the title of this session, Building Blocks of Strain Imaging, Part 1. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you all for joining us today and appreciate your participation.